Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hi everyone, Dan Ambinder here. On behalf of all of us at CardioNerds, we are thrilled to bring you our Decipher the Guidelines series for the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. Get ready for short and bite-sized, high-impact clinical vignette-based questions designed to highlight core concepts based on cutting-edge evidence that are relevant to your practice. The cases we use are hypothetical and for educational purposes only. This series was developed by CardioNerds and created in collaboration with the American Heart Association and the Heart Failure Society of America. It was created by 30 trainees spanning college students through advanced fellowship with mentorship from Dr. Lala, Dr. Robert Mentz, and Dr. Nancy Sweitzer. We thank Dr. Judy Bezanson and Dr. Elliott Antman for their guidance. So join us as we get to learn about the guidelines and beyond from 16 leading faculty experts. With that said, it's time to get nerdy.
The following question refers to Section 9.5 of the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. Questions asked by Keck School of Medicine USC medical student and CardioNerds Intern Hirsh Elhence, answered first by Cedars-Sinai medicine resident and soon-to-be Vanderbilt Cardiology Fellow and CardioNerds Academy Fellow Dr. Breana Hansen, and then by expert faculty Dr. Javed Butler. Dr. Butler is an advanced heart failure and transplant cardiologist, president of the Baylor Scott and White Research Institute, senior vice president for Baylor Scott and White Health, and distinguished professor of medicine at the University of Mississippi. Dr. Butler, welcome back to CardioNerds. It's nice to have you.
Absolutely delighted to be here.
Mark, thanks so much for that intro. So, Bree and Dr. Butler, I have a patient that I'd love to run by you guys. So our patient is Mrs. Hart. She's a 7-year-old woman who was admitted to the CICU 2 days ago for signs and symptoms consistent with cardiogenic shock. Since her admission, she's been on maximal diuretics and requiring greater doses of IV dobutamine. Unfortunately, her liver and renal function continue to worsen, and her urine output is still decreasing. A right heart cath reveals elevated biventricular filling pressures with a cardiac index of 1.7 liters per minute per meter squared by the thick method. What's the next best step? And so the answer choices are A, continue current measures and monitor for improvement. Option B is switch from dobutamine to norepinephrine. Option C is place an intra-aortic balloon pump. And option D is resume guideline-directed medical therapy. And Bree, I have absolutely no idea what the answer is. I would love your help figuring out what the next step should be.
Hirsh, thank you for that great and very complex question. The correct answer is C, place an intra-aortic balloon pump. This patient is in between the SCAI shock stages C and D with elevated venous pressures, decreased urine output, and worsening signs of hypoperfusion. She's been started on appropriate therapies, including diuresis and inotropic support. The relevant Class 2A recommendation is that in patients with cardiogenic shock, temporary mechanical circulatory support is reasonable when end organ function cannot be maintained by pharmacologic means alone to support cardiac function. The next best step at this point is thus a form of temporary MCS, an intra-aortic balloon pump. An intra-aortic balloon pump is appropriate to help increase coronary perfusion and offload the left ventricle. In fact, for patients who are not rapidly responding to initial shock measures, triage to centers that can provide temporary MCS may be considered to optimize management. The guidelines further state that in patients presenting with cardiogenic shock, placement of a PA line may be considered to define hemodynamic subsets and appropriate management strategies. And so, if time allows, escalation to MCS should be guided by invasively obtained hemodynamic data via PA catheterization. Several observational experiences have associated PA catheterization used with improved outcomes, particularly in conjunction with short-term MCS. Additionally, PA catheterization are useful when there is diagnostic uncertainty as to the cause of hypotension or end organ dysfunction, particularly when the patient is in shock and is not responding to empiric initial measures such as this patient. There are additional appropriate measures at this time that are more institution dependent. An institutional shock team would be very helpful here, as they are often comprised of multidisciplinary teams of heart failure and critical care specialists, interventional cardiologists, surgeons, and palliative care specialists. As such, there is a Class 2A recommendation that in patients with cardiogenic shock, Management by a multidisciplinary team experienced in shock is reasonable. Most documented experiences have suggested outcomes improve after shock teams are instituted. For instance, in one such experience, the use of a shock team was associated with an improved 30-day all-cause mortality and reduced in-hospital mortality. Let's go through why the other choices are incorrect. Choice A, continue current measures and monitor for improvement. This is incorrect as the patient has been deteriorating on current measures since admission and is at a higher SCAI shock stage E, extremis, refractory hypotension, hypoperfusion, and cardiac arrest, and therefore requires escalation of therapy. Choice B, switching from dobutamine to norepinephrine is also incorrect. The Class 1 recommendation is that in patients with cardiogenic shock, intravenous inotropic support should be used to maintain systemic perfusion and maintain end organ performance. Dobutamine is a more potent inotrope agent than norepinephrine. Therefore, stopping dobutamine in the setting of her low cardiac index would be incorrect. And finally, choice D, resuming guideline-directed medical therapy is incorrect, as this patient's shock is getting worse. The Class 1 recommendation is that in patients with heart failure, GDMT should be initiated during hospitalization after clinical stability is achieved. Restarting her medications now would be premature. So to sum this together, the main takeaway, in patients with cardiogenic shock, temporary MCS is reasonable when end organ function cannot be maintained by pharmacologic means to support cardiac function. Dr. Butler, we would love to hear your thoughts on this question.
Yeah. So, this person is really sick. And as you said, they are sort of somewhere between SCAI C and D category. They meet the criteria just by hemodynamic classification, cardiac index of 1.7. They are way down there. We don't have all the hemodynamics, but one can be certain that their wedge pressure is greater than 20. CVP is also quite high. Their mixed venous SAT is probably pretty low, 40, something like that. So this person really is in trouble. And what really highlights here is not the beginning hemodynamic, but the lack of response to medical therapy. So that's sort of the biggest take-home message here, is that this person required higher doses of diuretics, and that did not result in diuresis, but all it resulted in is in decrease in urine output rather than increase in urine output, worsening renal function, and increased need for inotropic therapy. So this is a perfect example, right? When we give diuretics to patient, there is still some sense that if the creatinine bumps, that something is going wrong and people tend to withhold the diuretic. But obviously the difference is that if you're responding to diuretics and diuresing and your edema is going down, then we ignore that creatinine. But if you're not diuresing, you're not, getting rid of excess fluid, and yet, if anything, your creatinine is going up, and you require more pressors and inotrope support, that's a sick heart. That's a sick heart. So you need to do something more. Well, what more are you going to do? This person is already on max doses of diuretics and is on intravenous dobutamine. If this person was kind of sort of maybe semi-stable, and now we are in a really gray zone by what is meaning of the word stable, one can argue, well, should you try both dobutamine and milrinone together? But boy, this person really needs mechanical circulatory support. There's a 2A recommendation in the guidelines for a person like this who is in cardiogenic shock and is going in the wrong direction, not responding to medical therapy and requiring extra hemodynamic support. So I think placing an intra-aortic balloon pump is an incredibly reasonable next step. Now, what to do with this patient once you do have the balloon pump in. So that depends on why is this person not doing well. So if this person is, acute myocarditis, if this person is acute coronary syndrome, but has been revascularized, if there's some ray of hope that this person is going to recover, then you'll just basically continue all the drips that you had, put the balloon pump in, and then over the next few days, start cutting the drips back and see how the person does. And after giving the heart some rest over time, if the cardiac function improves with whatever else you're doing, either natural history of the disease and myocarditis, whether there is some specific therapy you're giving, you're able to give some other medications in terms of chronic therapy that you're able to slowly institute at the same time, cutting back on the inotrope therapy. In other words, everything is turning in the right direction, then sure, you can start weaning the balloon pump off after the drips are off, and after some time, you just withdraw it. The problem is that if that doesn't happen, and if this is not some acute hemodynamic catastrophe, but this is basically just chronic heart failure, which has just gone south, and this is, the third admission in the hospital for this patient, and is really advanced heart failure. This is the time when you start thinking about moving on from balloon pump to some more permanent form of ventricular support and evaluation for transplant if the person otherwise is younger and does not have any contraindications for definitive therapies, VADs, and transplant. And unfortunately, if they do, then you might want to give some finite period of try to see if things recover. I don't know what that would be. It will be individualized, a week, something like that. But then really start talking to the family members and about potential for withdrawal of care, what the long-term plans are, what the patient's wishes are, what the family wishes are. So this is really not a cookbook sort of a situation. It just has to be individualized depending on the patient factors, depending on the response to therapy, and depending on what is the trajectory. And again, to more carefully manage this patient, at least my bias is a little bit of a lower threshold for using right heart catheterization and hemodynamic monitoring of these patients, because that can at least take away that guessing game that if somebody is not responding to even the balloon pump, or every time you try to wean the balloon pump, their hemodynamic gets, out of whack, and what exactly is going on. I think if you do that under some hemodynamic guidance, you're able to make the decisions much more accurately and perhaps a little bit faster. So at least that would be the way I would approach this patient. But completely agree with your idea that this person really needs an intra-aortic balloon pump placed.
Dr. Butler, thank you so much for that amazing explanation.
Great talking with you guys.